Hi, everyone. Welcome. So nice to see you all. I can see the numbers going up. My name is Kimberly Brunel, and I'm the Manager of Education and Support Programs at PHA Canada. I'm thrilled to have you join us for this month's webinar, PH 201, a more advanced look at pulmonary hypertension. Some of you might be very familiar with our PH 101. Well, we've sort of jacked it up a little bit, and we're just giving you a little bit more information, or as Sanjay's called it, University 201. So get ready to be a student again. So without further ado, I will quickly introduce Dr. Mehta, and then we can get started. I think most of you already know him, but I'll do his bio anyways. Dr. Mehta is a professor of medicine, consultant respirologist with Western University in London, Ontario, and he's also the director of the Southwest Ontario PH Clinic at the London Health Sciences Centre. Dr. Mehta is also a founding board member, past chair of the board of directors, and an eternal friend of PHA Canada. He has been looking after PH patients for over 30 years since his start over at McGill in 89, and now he's been working in London since 1996. So I couldn't think of anybody better to do this webinar. So Dr. Mehta, thanks so much for being with us today, and I'm going to pass it over to you.
Thanks very kindly, Kim.
Welcome.
Great to join you all. Always fun to chat about pulmonary hypertension, obviously dear to my heart for more than 30 years, as Kim said, and obviously very dear to all of your hearts, patients, caregivers, friends of patients, and all of our wonderful Canadian PH community. So fun to chat. So I was challenged with sort of pushing us forward. Many of you know a lot about pulmonary hypertension, and let's sort of challenge you to learn a little more in depth. And I thought, why not have you understand exactly what we physicians are thinking these days and how we're assessing and looking after patients with pulmonary hypertension. If you know that, then clearly it makes you more capable of participating in your care with your physician. And I'm sure you all have great PH docs across the country, my colleagues. And if you're not close to one of the centers and you're being looked after elsewhere, to make sure that you're getting what we think is the best care. And you can challenge your physicians saying, well, I'm supposed to be having this done. And so I think this is a very important idea to have you understand exactly what is required today in the optimal diagnosis and management of pulmonary hypertension. So what I'd like to leave you with is really three ideas. How should pulmonary hypertension be diagnosed? Many of you know lots about that, so I'll be fairly short on that. More importantly, our ideas have changed about how we follow patients with pulmonary hypertension. How do we assess you? How do we look at how well you are or how not well you are? How do we monitor your disease? And then, of course, how do we optimally treat you in this day and age with all the wonderful medications that have been developed and the other approaches as well? Now, all of you know what pulmonary hypertension is. Just to be on the same page for those of you who might be new to the community, I love this graphic on the bottom right. It comes from our friends and colleagues in the US PHA. It's the other high blood pressure. And I use this idea a lot when patients first come to me and their families and they don't know what pH is. Everybody knows what high blood pressure is, and it's high in the arms and legs and the head. That's the standard kind of high blood pressure, but not high in the lungs in people with high blood pressure. So pulmonary hypertension, of course, is high blood pressure in the blood vessels specifically that feed the lungs, also known as PAP, pulmonary artery pressure. And as many of you know, it's not a single disease. It's serious, it can be progressive, it can often be fatal, sadly, but it's a syndrome, which means there's lots of different causes of PH. There's not a single disease. That's the best way to think of pulmonary hypertension. And of course, once the pressure's up, really important that all of you understand, I worry about the right side of the heart, because with the increased pressure, there's more load, there's more stress, and eventually there's failure of the right side of the heart, specifically the right ventricle or the RV. And we'll chat a lot about that. It is an important concept, so I just put a little schema in here. Compared to most of us who have healthy hearts and lungs on the left side, on the right side, you see what happens in pulmonary hypertension. Because of changes in the blood vessels that feed the lungs, the pulmonary arteries, they get thickened and scarred. Sometimes they're even closed off completely, and that's why the pressure goes up. So the pulmonary artery pressure goes up. That's pulmonary hypertension. And then for you to still be alive, the heart, the right side of the heart, has to work much harder to force the blood through these pulmonary arteries at the high pressure. And so not surprising, the right side of the heart, the right ventricle or RV gets thicker and stronger. That's called hypertrophy. And then fairly soon thereafter, at some point, it starts to get dilated or bigger. And then it starts to get weak. And once it gets weak, we call that right ventricular or RV failure. So the disease is pulmonary hypertension. The main complication is right-sided heart failure. And those both determine how you're going to feel, how you're going to function, and very importantly, how you're going to do in the future. Now, we teach doctors, obviously, how to recognize pulmonary hypertension, how to diagnose it based first on the symptoms. And many of you know the symptoms of pulmonary hypertension. The common things you see there, most commonly being short of breath, being tired, eventually getting swelling of your feet and ankles. And then when it's severe, pressure, tightness, pain in the chest, lightheaded, or passing out, syncope. The problem is, at the start of the illness, the symptoms are quite subtle. They can be quite mild, and many patients downplay them. I'm out of shape. I'm going up a flight of stairs carrying laundry. Of course, I'm going to be short of breath. But because they're subtle, we ignore them. They're going to progress, and then we have to obviously pay attention. It's also important, a lot of these symptoms are not specific for pulmonary hypertension. That means that many other heart and lung diseases that you've all heard about, asthma, COPD from smoking, heart failure, even anxiety or stress can cause many of the same symptoms. That makes it difficult to diagnose pulmonary hypertension. Clearly, as the symptoms progress, people become more limited, eventually possibly disabled. And there is obviously in pulmonary hypertension, if it's not diagnosed and treated, there is a high risk of death. Wonderful statistics from the British PHA, the UK and PHA, and many of you know this. They found of more than 500 people they surveyed, 48% had waited more than a year until they got diagnosed. I do believe our numbers in Canada are better. Last we did the survey, I think the average was around 6 months. Still a long time, and we're working on making that better. And sadly, on the top right, you see that 40% of patients had seen 4 or more doctors before they got diagnosed. So there's still a lack of awareness out there, a lack of comfort in thinking about pH in the medical field and diagnosing pulmonary hypertension. And so obviously we work at that in many ways. So let's focus first on how should pulmonary hypertension be diagnosed. And so for physicians, we try to teach them in many ways, one of which is through clinical practice guidelines, very important documents. And there's several excellent ones in the pulmonary hypertension field. This is one that I'm quite proud of. It's the Canadian group. You can see many of the authors there, people you would know, like my friend and colleague, Lisa Melnichuk, our PH colleague in Ottawa, who's also chair of PHA Canada as of this year. So we're very excited, as well as other colleagues across the country. We published this in 2020 to help Canadian physicians understand what pH is and how to look after patients. There's also excellent European guidelines that came out in 2022. Some of the world leaders in pulmonary hypertension, again, focused on what is the current best evidence for diagnosis and treatment of pulmonary hypertension. So all those are being spread to physicians. Doesn't mean they're always used, and so we have to do other things, which we do at PHA Canada. This graphic is wonderful. It's from the European guidelines, and it summarizes an important concept about pH. When I was training 35 years ago, it was said to be rare. Pulmonary hypertension is not rare anymore. I've been saying that for many years. In fact, the guidelines agree that 1% of the global population and 1% of Canadians are at risk of pulmonary hypertension in their lifetime. So what that means is 40 million population, we're looking at 400,000 people in Canada at risk for pulmonary hypertension. Now, there's many kinds of pulmonary hypertension. Obviously, in diagnosing it, we have to be clear what kind you have, because that then helps me know what the best treatment is. And many of you know the classic 5 groups defined by the WHO, the World Health Organization, groups 1 to 5. Group 1 is specifically pulmonary arterial hypertension, or PAH, due to many things, for example, idiopathic, no obvious cause, and other things that we'll chat about. And this clearly is what we would think of as a rare disease. That's important. Similarly, the other one that's really important for us to always think about is group 4, pulmonary hypertension due to things that are plugging up the blood vessels in the lungs, so pulmonary artery obstruction. And the classic one is CTEPH, chronic thromboembolic pulmonary hypertension, people who have had blood clots either recurrently or multiple, and they end up with pulmonary hypertension. And groups 1 and 4 are the ones that we have focused a lot of work on in terms of research, in terms of treatments, and that's what we look after commonly in the clinics. And obviously, both of those are still rare. Much, much more common. Many patients out there with pulmonary hypertension have not yet been helped by us or our treatments, and they have pulmonary hypertension, typically in group 2, pulmonary hypertension due to left heart disease. So we will chat a bit about that. That is the most common cause of pulmonary hypertension. Of everybody that I see or see in other clinics, we're talking about 50% of patients with PH have group 2 PH. Similarly, pulmonary hypertension due to lung disease, also very common, and about 40% of all people that come in with new PH, it's because of lung disease. There is a category 5 or group 5, and the title kind of says what it is. It's unclear, or there's multifactorial, multiple mechanisms. So this is the rare of the rare. And there are a few things that I look for when I see people, but most commonly this is not playing a big role. So it's really 1 to 4 that we're focused on. And diagnosis, it's critical 1 and 4, where we have a lot to offer treatment-wise. All right, let's go forward. So how do we get doctors to think about pulmonary hypertension and diagnose it sooner? Well, first and foremost, to have them understand that it's not everybody that's at the same risk. There are some people at higher risk. So risk factors for patients to develop pulmonary hypertension. And like I said, the most common causes are if you already have chronic or significant heart disease or lung or respiratory disease, then you're at risk for developing pulmonary hypertension, groups 2 and 3. So that's an easy one. But the less common ones, groups 1 and 4, I need people to understand that if there's a family history, this patient could have hereditary pulmonary hypertension. That's because of genetic defects, which we'll chat about. There are many medical conditions which can cause PAH, pulmonary arterial hypertension group 1, the most common of which is connective tissue disease like scleroderma. I'm sure many of you out there have scleroderma. It's one of the most common things seen in our clinics. But there are others, people with liver disease, people born with congenital heart disease at birth, people that had infection with HIV. So those are also very important categories that also fall into group 1 PAH. And then we mentioned group 4, CTEPH, chronic thromboembolic pulmonary hypertension. And the biggest risk factor is anybody that's previously had a blood clot or a pulmonary embolism. Then we have to definitely think about CTEPH in those people. Increasingly, the last 5 to 10 years, there are people developing pulmonary hypertension because of various exposures. This was not that big prior. For a long time, we've had medications like anorexogens that caused pulmonary hypertension when people were taking them to lose weight. We had epidemics in the 80s and the 90s, but not much in the last 20 years because they kind of disappeared off the market. But there are new anorexogens and there's new medications in the type of chemotherapy drugs that we use, which can cause pulmonary hypertension. And then even more important, in many centers in the US, my colleagues run, the most common cause of new pulmonary hypertension in group 1 PAH is indeed recreational drugs, especially amphetamines, a little bit cocaine as well. So good things for us to know in Canada because we are seeing those as well. So these are important. Risk factors when you're seeing a patient who's short of breath or has heart failure symptoms with swelling, always thinking, could they have PH if they have one of these risk factors? Now, we also know that many patients have lots of testing when they're not feeling well. And so pulmonary hypertension can be picked up on various common tests. For example, this is the classic chest X-ray of a patient that might have pulmonary hypertension. And what you see is this is the lung fields, there's the heart in the middle, and these blobs are the pulmonary arteries that take blood from the heart to the lungs. Now, these arteries are very big, much bigger than they should be. So if they're big in those areas, that's an important sign that radiologists know, and they will report this patient could have pulmonary hypertension. Similarly, on the side view, what you see is this is the heart, and the specific part of the heart here behind the breastbone or sternum is the right ventricle, the RV that we talked about, which gets bigger and weaker in pulmonary hypertension. So in this case, the right ventricle is very large, and that's also a clue that this patient has pulmonary hypertension. We also do electrocardiograms, or EKGs, in all of our patients, often when they come in short of breath, chest pain. And there are some classic findings which cardiologists know, technicians know, and they get reported as possible pulmonary hypertension. For example, the heart normally has an axis along which it beats. And this changes in pulmonary hypertension. It's called the right axis deviation, and it's based on the electricity changing in the first lead. Similarly, the right atrium is another chamber of the heart near the right ventricle, and that gets larger, and we see these very tall P waves, which are a sign of that. Similarly, the right ventricle, we talked about getting thicker and stronger, and so this R wave here is very high, much too high for normal. It's a sign that the right ventricle is indeed thicker. So there are clues on EKGs as well. Finally, people that are short of breath often have pulmonary function tests, or PFTs. Very important for people who are short of breath. You might have asthma or COPD, so looking at how the flow of air is. In pulmonary hypertension, of course, it's normal. You might have scarring of the lung, something called fibrosis, that makes you short of breath. In pulmonary hypertension, the size or the volume of the lung is normal. So pulmonary hypertension affects how the lung can handle gas exchange, especially oxygen. So you can have reduced oxygen levels in the blood. And we can measure something called the diffusing capacity, a very nice simple test called the DLCO, which can measure how the lungs handle gas, and very importantly, is often affected in pulmonary hypertension. As well, I'm looking for other causes. Like I said, is there lung disease causing your pH? So I can look for lung disease like COPD or asthma. I can also look for scarring or fibrosis of the lung on the pulmonary function test. So in simple terms, we get to a diagnosis of pulmonary hypertension these days if a patient has a good doctor who knows about pH and is careful and says, you know what, the symptoms you have could be pulmonary hypertension. Or on examining you, they find some physical exam findings or signs that suggest pulmonary hypertension. That's really important. Or all of the testing we talked about, the EKG, chest x-ray, and PFTs, if they see those abnormalities typical of pulmonary hypertension, or whoever's reporting them, like I report PFTs for my colleagues, they might see my report saying, think about pulmonary hypertension. Then they should be thinking about it. So in any of these situations, if you're thinking about pH in the community, it's right to go on to the next test. And the best test, of course, is an echocardiogram. An ultrasound of the heart, very good at picking up pulmonary hypertension, very safe, simple test, and it gives you a very good sense of how likely you are to have pulmonary hypertension, or the probability of pulmonary hypertension. Now, if we go back to the Canadian guidelines, you can see, recommend a transthoracic echo from the outside for initial assessment of any patient who you suspect might have pulmonary hypertension, or even patients that have dyspnea, shortness of breath, that's unexplained. It's such an important test that'll pick up heart disease and pH and other things that it's strongly recommended. So strong recommendation, and there is good evidence, not the strongest, but moderate quality. It's also important, this is not a simple echo. We recommend a complete echo. There are multiple things which have to be looked at carefully. The European guidelines showed us a great graphic. There's 16 abnormalities on this slide that need to look at for pulmonary hypertension. Now, some of these are more for research. They're very important, and we might learn more about them in the future. But of the 16, there's about 6 that I need to see in echoes today that help me assess whether you have pulmonary hypertension, how much heart failure on the right side, the RV you have, and what possible causes you might have. So that's important. You don't need to do all 16 all the time, but like I said, there's about 6 features that I need to see in every echo. So it's very important. It's not a simple echo. but all echo labs know how to do this. Back to the guidelines. And so the echo says, yes, you have pulmonary hypertension. Good. Now I need to go forward. I need to figure out why you have it. So it goes back to this idea of group 1 and 4 being really important because I have many treatments to offer you. And if I don't treat you, survival is very poor and your quality of life is poor. If it's group 2 and 3, then so far we haven't had a lot to offer those patients. And it is a shortcoming of what we've done in terms of pH. And we obviously have lots of work to do, which we'll chat about. So first thing is sorting out the common stuff. Now, how we do that is many different tests. We look for blood clots, that's for group 4. We look for lung disease, obviously group 3, breathing tests, we talked about that. CAT scan, very important to look at the lungs. So those are all pretty easy. The hardest thing is, do you have group 1, PAH, or do you have group 2, heart disease? Because heart disease is the most common, and group 1, PAH, is really important, so I need to sort this out because I need to treat those people. So the best way to do that is what many of you know, hopefully many of you who have PH have gone through this, it's the right heart catheterization, or the Swan-Ganz is the proper term. And what this means is the echo from the outside has said, I think there's pH. It's not a perfect test, but this is now taking a little wire. It goes down from the vein in your neck, through the heart, all the way out into the blood vessels of your lungs, the pulmonary arteries, and that little tip there measures the pressure inside the blood vessels of your lungs. That's what I need to measure pulmonary artery pressure, PAP, which is the blood pressure of the lungs. This is the actual catheter. It's quite an amazing invention that goes back to the 50s. It has a little balloon on the tip, and so the balloon actually floats with blood flow while we use the other parts of it to monitor things. Now, what I measure with this is the pulmonary pressure. I also measure what's called the right atrial pressure, the pressure in the right atrium near the ventricle, and that tells me how much heart failure you might have. I can also measure cardiac output. How much blood is your heart pumping? And that's a good sign of heart failure as well. I can also measure the PVR, pulmonary vascular resistance. How stiff are your blood vessels? How many of them are blocked up completely? Because that's a good measure of the severity of your pulmonary hypertension. And then I said, most common cause of PH is group 2, heart disease. I need to assess whether you have left heart disease that might be causing your pulmonary hypertension. So I measure what's called the wedge pressure, or PAWP, a really important concept, and we should do it on every cath to make sure that your pulmonary hypertension is not group 2 from heart disease. It's actually from the lungs themselves, the blood vessels getting scarred and narrowed like I showed you. And that's important because then I can treat you and help you. We can also do some measurements to look at whether or not you might have something you were born with or congenital heart disease. So Swan-Ganz right heart catheterization is such an important test, a wealth of information, and the most important, to being very clear why patients have pulmonary hypertension. Not a simple test, which is why it really ideally should be done at one of the expert centers across the country. As you know, we're very lucky. We have 22 expert centers scattered from Vancouver to St. John's, Newfoundland, close to most Canadians. Of course, a lot of peoples in the north are not well covered by these centers, and that's something that we're still working on, improving their access to care. So back to the 5 groups. We want to talk a lot about PAH today because that's where we've got a lot of treatment options. We're going to talk also a little bit about CTEPH. I mentioned before, group 4, CTEPH, blood clots and lung that add up over time to scar the lungs. And I put them on this side because they have specific treatments. That's very important. Groups 2 and 3, I always sort of worry, have limited options. Most importantly, it's look after the heart disease, look after the lung disease as best you can. And then we typically have not needed to treat the pulmonary hypertension. And group 5, like we said, is very unusual, so we don't focus a lot on it. So importantly, group 1 has become a much bigger category. It used to be very simple. It was called primary pulmonary hypertension. As some of you might know, primary meaning no cause, but all of these causes now cause PAH, which is exactly the same. Primary became idiopathic, but I said before, it can be genetic or heritable. We have a couple of different gene defects that are the most common, especially BMPR2. So these are mutations in your genes in the cells of the lung that cause the narrowing and scarring of the blood vessels of your lungs. There's now more than 10 different genetic defects that have been found that cause heritable pulmonary hypertension. I mentioned briefly that various medications and toxins like methamphetamines can cause this. As well, there are associated conditions, connective tissue disease, scleroderma, and others that we mentioned. The crazy thing I mentioned briefly, methamphetamine use is uncontrolled, especially in the richer countries, US, Canada, Western Europe, Australia, South Africa. It is becoming the most common cause of PAH. So a lot of patients out there we're going to be seeing over the next few years. And the funny thing is, even though it's related to a drug, the talc, like talcum powder that deposits in your lungs that you see here, causes the same changes in the blood vessels of your lungs that we used to see from idiopathic or scleroderma or any other cause of PAH. So the disease is changing over time based on the new things that are coming along and what people sadly do to themselves. Briefly, group 2 PH, most common. Any heart disease you've ever heard about can cause group 2 PH. This is an X-ray showing water in the lungs or pulmonary edema because of heart failure. This is showing a very thick, strong left ventricle, not the right, but the left, is somebody that has high blood pressure or diabetes, and that can cause pulmonary hypertension. This is somebody that has a narrowed and scarred mitral valve, and that can cause pulmonary hypertension. This is somebody that has an irregular heartbeat, atrial fibrillation, and that can cause pulmonary hypertension. Very common. You have to look after all the different aspects of heart disease, and that typically does help people who have pulmonary hypertension from heart disease. Similarly, being a lung specialist, I see a lot of people who have lung disease who could develop pulmonary hypertension. So if you have severe emphysema, the lungs are really black here because they're full of holes, and you see it on the breathing test, severe COPD, and typically people need oxygen and lose weight. That can cause pulmonary hypertension. People with scarring of the lung, all this haziness, and on the CAT scan, the scar tissue, that's called fibrosis or scarring, they get pulmonary hypertension. And then people that have sleep apnea, stop breathing at night and get low oxygen levels, they get pulmonary hypertension as well. In all of these cases, the key is low oxygen levels. So we do monitor people with lung disease, looking for low oxygen levels, looking for pulmonary hypertension. And if you find those things, being aggressive, treating the low oxygen, easy enough, wearing oxygen, but also sometimes having to do more for them. We have an incredible array of medications now available in Canada, thanks to research that's gone on over 30 years, approvals from Health Canada, and most fortunately, approvals from provincial ministries of health to say they'll pay for, if not all these medications in all provinces, most of them. We're very lucky in Ontario, all of these are paid for. They're mostly for group 1 PAH. And yet there is excitement because it has been tested and now becoming available to use in other patients as well. And so we'll chat a little bit about that. In fact, Tyvaso, inhaled prostacyclin, like the intravenous or subcutaneous, became the first treatment ever approved in group 3, specifically if you have interstitial lung disease or fibrosis, pulmonary hypertension. They then have access to this in the US as of 2021. Not yet approved in Canada, but we are hopeful at some point in the future having access to this. And of course, lots of research going on in group 3 PH and group 2 PH, looking for treatments for those patients, which we don't have very much of. So given that, when we're seeing patients like you, how should we best monitor you and assess you for your pulmonary hypertension and deciding on treatment? Now, this is really important. I'm going to propose to you a little framework that I'd like to use. The disease, we said, is high blood pressure in the lungs or pulmonary artery pressure and pulmonary vascular resistance, PVR. That's the disease of PH. We said the main complication is right-sided or right ventricular heart failure. But you don't care about those. You care about what you feel and what you can do from day to day. And that's what we would call outcomes, clinical outcomes. What happens to patients, what you feel, how you can function, and how you live life, and how obviously how you survive. And so we know you have the symptoms we talked about, especially being short of breath. We know that you have trouble functioning in life on exercise, occupationally, even socially or recreationally. And we know that you get sick enough to get hospitalized. And all of those contribute to overall what's been measured as a poor quality of life when you first get diagnosed with pulmonary hypertension. So those are the important things that you feel and want us to focus on. And it's important we recognize that. And of course, at the end of the day, if we don't diagnose and treat you, we also know that people with pulmonary hypertension don't survive as long. So this is the disease, pulmonary hypertension. This is the complication, right-sided heart failure. And these are the outcomes that we need to look at. Now, a few years ago, a colleague of mine, Luke Howard, in London, funny enough, England, not London, Ontario, and also Pisana Ferrari, who's a patient of pulmonary hypertension, who underwent transplant. And she was one of the key founding members of PHA Europe. And so we wrote a paper on what are the expectations that patients have versus people like myself, PH healthcare providers. And not surprising, there are overlaps, but they're not the same. And so what you see is high priority for patients is, of course, improve their symptoms, let them live life better, but also improve their survival. Not surprising for me, also very high priority. I want you to be better from day to day, to live better, to function better. I also want you to live as long as we can have you live. Well, I also know that I need to measure many things. I need to measure exercise capacity and your function, like a 6-minute walk distance. I also need to measure the blood pressure in your lungs and the cardiac output, like I showed you with the right heart catheterization. Those are called hemodynamics. I need to measure some things in the blood, biochemical measures like BNP levels, which reflect heart failure. And I need to look at the right ventricle by some kind of imaging, either echo or cardiac magnetic resonance or MR. Those are important to me because I know that helps me measure your disease. Those are not so important to patients. Much more important to patients is the fact of quality of life. Get them to function better in everyday life, be able to go back to work, be able to be active recreationally and socially with their families. Obviously, pick treatment that's as convenient as possible. Nobody wants infusion therapies because they're challenging, complicated, and risky. And then, of course, we all understand that serious illnesses like PH have tremendous social and emotional effects on people, from being isolated, from being symptomatic, from feeling that you can't participate. And of course, there are financial effects as well that we've measured in the PHA of Canada burden of illness surveys. So those are very important to patients. So if we're going to improve you, I need to keep those in mind. I want to improve symptoms, function. I don't want you to get hospitalized. I want you to be better quality of life-wise. And of course, I want you to live as long as you can. So as we talk about treatments, those are the things to pay attention to. One of the concepts I want you to understand is risk. Once you have pulmonary hypertension, some patients are more at risk for these complications and outcomes than others are. And so we clearly see people when they first come to us, they typically have high risk or somewhere around medium or intermediate risk. That's not good. You're likely not to be well unless I can improve you. So my role is to assess you, but also then using the treatments we have, try to pull that risk back to low risk. And then you're going to feel better, and I'm going to feel better that you're going to do well in the long term. So that risk is something that we assess now for every patient at every visit. So how do we do that? So this is the framework. It's a little complicated. Let me take you through it because it is important. It is the best way today to assess PH patients. This is the European framework based on the French registry from France. In simple terms, I need to know, are you at low risk in the next year of getting worse and dying? They define low risk as less than 5%. Most of us now believe it's somewhere around 1 or 2%. That's very good if you have a 2% or less chance of dying in the next year. Conversely, high risk is not good. They define it as over 10%, Most of us now believe if you're in the high risk category, it's more like 20% or higher. So 1 in 5 chance or more that you may not survive the next year. And then, of course, intermediates in the middle. And so how do I do this? Well, I do this by looking at several different parameters. There's not that many. There's essentially 7 that I need to look at. 7, apologies, 4, 5, 6, 7, 9 I need to look at. And they come down to fairly simple things. First of all, assessing you clinically, doing something to measure your exercise capacity, and doing something then to look exactly at how your right ventricle, the right heart is working. Is it working well, or do you already have right ventricular failure, which is not a good thing? For example, if you come to me and we examine you, you don't have any swelling in the feet and ankles, I look at the vein in your neck, looking at the swelling, which is the jugular vein pressure, JVP. If it's not there, then I feel very good that you're not in right heart failure, you have a low risk. Similarly, if your symptoms are not progressing, you have not had syncope or fainting or losing consciousness, and your functional class 1 or 2, that's really good. Conversely, if you're in heart failure in the clinic when I examine you, if your symptoms are progressing, if you're having syncope or fainting repeatedly and you're class 4, then I'm obviously very worried. And in between, I'm still worried. I'm not happy if you're yellow. I also measure your 6-minute walk distance that most of you would have done. Over 440 meters, fantastic. I know that your heart and lungs work well. In fact, younger people, 440 is not even enough for me. I want you to be over 500 meters, and that's a really good sign that you are low risk. The lower it is, obviously 165 or less, I'm worried. In the middle, I'm also worried. I can also sometimes do more formal treadmill testing, which gives us even more information on how your heart and lungs are working. Probably the most important, other than the clinical evaluation, is how is the right ventricle. And I can look at that in different ways. We start at the beginning by doing the hemodynamics, doing the right heart cath, measuring the pressure on the right side of the heart. If it's low, you don't have heart failure. If it's high, I'm very worried about right heart failure or right ventricular failure. Similarly, I measure the cardiac index, the blood flow. If it's over 2.5, that's normal. Good, I feel better that you're low risk. If it's under 2, that's very abnormal and that's high risk for getting worse. We can also do this more simply, not having to do the cardiac cath over and over every year or every visit. We can use blood tests. I mentioned the BNP levels, and there are 2, BNP or NT-proBNP, and there are very clear levels that I want you to achieve. Under 300 for proBNP, under 50 for BNP is a great sign that you're not in heart failure, you're doing well. Conversely, if you're on the high side, I'm worried. And then we also use imaging, either echo or MR, I mentioned, looking at the right side of the heart. If you have all those changes, the heart's bigger and weaker, I'm worried. If it's not like that, things are looking normal, good sign. So this is how we do risk. Now, the point is this. We all want you to be well for a long time, but you also want to be well from day to day. So those relate to the 2 key goals of management that we have in pulmonary hypertension. I want you to be better clinically and to function on a daily basis as well as you can. And that means you're class 1 or 2. Class 1 means you're not limited in everyday life at all. You can exercise vigorously. It's uncommon to get most patients there with PH. Class 2 is very good. It means you can be quite active. You're not limited on the flat unless you're rushing or carrying something, and you're not limited going up a flight of stairs or more. So that's very good. That's the goal, that you're functioning well. 6-minute walk, I mentioned, over 440 or 500 in the young. That means you're functioning well. And then if I measure your quality of life, I use emphasis 10. There are many measures out there. This is a common one. If that's better, I'm happy that you're better on a day-to-day basis. But that's not enough. I need to know that this, in the short term, also tells me you're going to be well in the long term, the outcomes that we talked about. Another term for those outcomes is morbidity, mortality, illness, and death. Putting it all together, I don't want you to progress or get worse over the next months to years. I don't want you to get hospitalized. I don't need you to go on to infusion therapies or prostacyclin because they're complicated. It means you're getting worse. And obviously, I want you to survive as long as you can, being as well as you can. So 2 goals of management: get you better from day to day, symptoms, function, quality of life, and that will translate to getting you better in the long term with less progression, less worsening, and less risk of death. And that's where the risk comes in. The risk of having a bad event relates to this, how good you are when we assess you. So we do that when you first come in and repeatedly. How do we use that when we want to treat you? So let's go back to the schema of the different kinds of pulmonary hypertension. Sadly, as I've said, we're not going to talk about groups 2 and 3. There are no PH therapies in Canada for those patients. And again, it's a deep lack of sort of enough research and treatments, a lot of research going on. So I'm very hopeful the next 5 years, we will see more approaches for all these patients who, of course, are coming to us and wanting our help, like we've been able to do already for groups 1 and 4. Group 4, we're not going to talk a lot about today. It's a fantastically important topic. Most of myself and my colleagues all believe it's the most important kind of PH because it is curable. If you have pulmonary hypertension, pulmonary PH due to blood clots, I need to diagnose that with a scan, typically a nuclear lung scan, CAT scan sometimes, and then think about surgery called pulmonary endarterectomy, PEA, to go in and take out the clot and scar. And it's a big operation, but in the proper hands in a few centers in Canada that do this, we're looking at your risk of not surviving that as being much less than 5% for a 7 in 10 chance that you're cured of your pulmonary hypertension. So really, really important that we always look for that and try to be aggressive. If you can't have surgery or surgery doesn't work, we have medications. We also have new procedures called angioplasties, balloons that go into the pulmonary arteries, again, through the neck, and they can open up those blood vessels where the clot and scar still are. So lots of important options to treat group 4 CTEPH. I'm not going to talk about that today. I think what we'll do is probably plan another specific webinar. Let's focus a lot on group 1, PAH. How do we treat PAH? Well, it comes down to understanding what the disease is. A long time ago, 30 years ago, we thought that the pressure was high in your lungs when you had PAH because your blood vessels had gone into spasm. They were closed. We just need to relax them and open them, and you'd be better. That's not the case in most people. There are a few people like that, more commonly when you're young and in children as well. In most people like you who have PAH, whatever cause, idiopathic, heritable, scleroderma, or others, we know that it's largely because of what's going on in your blood vessels of your lungs, which is like a cancer. Cells have grown and multiplied excessively, and that's what's plugging up. This is a normal pulmonary artery in most of us, hopefully, and here you see it's plugged up because there's too many muscle cells, thickening the wall and narrowing where blood flows. These are endothelial cells, which typically line the inside of blood vessels, and here they've grown and they've formed all these funny little channels like canals, but the main pulmonary artery is mostly plugged up. So it's the excessive growth and multiplication of these cells that's led to narrowing, scarring, closing off of the pulmonary arteries. And this is important because this is indeed fibrosis or scar tissue that's a response to the cells growing. So all 3 of these are going on in the lungs of people with PAH, and that's why we call it like a cancer. It's not a cancer, but it's like a cancer. Now, knowing that, how do we treat it? Well, again, we're really fortunate, 30 years of fantastic research. There's a lot of ideas why these cells have grown and multiplied, many different chemicals and hormones and other molecules that circulate in the blood and in the lungs that cause this. 3 of those, very important, endothelin, nitric oxide, and prostacyclin, have the most research, and we're lucky because there's treatments that target all of these pathways. In brief, you can have excess endothelin. Too much of this causes the scarring and closing of blood vessels in the lungs. Nitric oxide and prostacyclin are normal. They keep the blood vessels in the lungs open and relaxed. Sadly, patients with pulmonary hypertension have less nitric oxide or they're deficient, and they have less prostacyclin. And so we have to help them and find ways to give it back or help the nitric oxide and the prostacyclin in their bodies work better. And so we have medications that target all three of those. And that's why I say, even though it's not a great disease still, we're so fortunate to have medications that target all of these abnormalities in PAH patients. So back to the drugs, 10 different ones available. Like I said, all funded in Ontario, which is very important and very fortunate. The oldest ones are the infusions. We had first Flolan or epoprostenol. Fantastic treatment, first got in 1997 in Canada. A little challenging, ice packs, keeping it cold. Caripul is the similar version that's stable at room temperature, so you don't need ice packs. It makes it much more convenient. And then Remodulin is the subcutaneous or intravenous form of a prostanoid. So all three of those infusion therapies. Now let's be clear. I say this to patients all the time. If I had severe PAH today, diagnosed, I would be on one of these infusions tomorrow. The best treatments we've ever had and still have, the most effective. When you come to me, if you're very sick, you're getting admitted to hospital, we're starting an infusion, and I'm confident most people within 7 to 10 days are getting better. They're challenging, which is why we don't use them always first, and there's still a minority of Canadian patients, less than 10%, probably less than 5%, who are on infusion therapies, and that's because they're complex and risky. And we have lots of effective oral medications, all the other 7, which is why we use those. But they're always in the background. We have our infusion therapies. Early on, what we saw was, they were complex, but patients are smart. Like all of you, they could learn to look after them. It takes a catheter that sits in the vein in the neck, and the drug is running continuously 24/7. It takes a little 100 ml, half a cup cassette that you have to fill every day with the drug and with a little liquid that makes it stable. It's not a lot of work, 20 minutes a day. You have to program the pump so it gets running again, and it works for 24 hours. Next day, you do it all again. So 20 minutes work. You obviously have to do it accurately, and you have to do it as clean as you can, because this line goes right into your bloodstream, and you can get infections, which are, of course, serious. If you get bacteria or germs in the blood, it leads to sepsis. And so very effective treatment, but complicated, which is why it was never used very widely. But important to recognize, in the first study ever that looked at this in 1996, still applies today. These patients came in incredibly sick, severe pulmonary hypertension and heart failure. If they started on prostacyclin, over a short 3 months, nobody died. Those people that didn't get treatment, standard treatment, which was essentially nothing back in those days, 8 out of 40. So 20% of those people died. So really, really important treatment that we still refer to when people come in very sick. Now, intravenous is difficult, in a vein, risk of infections. So the subcutaneous version, known as Remodulin or treprostinil, also very effective, also an infusion, but it goes through a tiny needle under the skin, smaller pump, not a half a cup, but 3 milliliters, less than a teaspoon of liquid. And so again, very easy to inject, insert, and look after. There are side effects at the site, pain and rash that can be quite significant, but a very effective treatment that we use regularly as well. Because of the complexity, I mentioned that we needed more, and we're very lucky to have 7 different oral medications or pills, starting with Ocentin and sildenafil, Revatio, now 20 years ago, or more than 20 years ago. What do those medications offer compared to the infusions? Well, very simply, if we measure over the first 3 to 4 months the benefits of the oral therapies versus the infusions, it's very similar. They're not as quick. It takes at least 2, sometimes 3, 4 months for you to start to feel better, but at 3 months, 4 months, 6 months, very similar effect to the infusions. Again, if you're very sick, I want you better in a week, I need the infusions. If you're not that sick, then we can be patient and try the oral medications. And the evidence is very good. For example, we said that you can't function well in life. I want to make you function better. I measure that with the 6-minute walk test. And so the Bosentan or Tracleer studies way back in 2001, first one to show that over a short 12 to 20 weeks, people walked much farther, between 50 and 70 meters, compared to those people on placebo. So people feel better, less short of breath, less symptoms, and they can function better in everyday life. As well, we talked about the idea of long-term morbidity mortality, the disease progressing, you getting hospitalized, you needing infusions, you needing a transplant, or you not surviving. That's all collectively called morbidity mortality, if you put it together. And we want to reduce that. Macitentan or Opsumit is the other endothelin antagonist in the same family as Bosentan or Tracleer. And this is the famous Seraphin study from 10 years ago that showed if you're on placebo, roughly 50% of people over 36 months or 3 years had something happen. They had morbidity mortality, which is most often progression of disease, and they need new treatment, like intravenous or subcutaneous infusion or a transplant. A small number died. And if you took macitentan, the right dose of 10 milligrams in the dark green, it made it 45% less likely that you would have an adverse clinical outcome. So you were more stable and better for up to 3 years. So very important data from studies of pills. Similarly, you mentioned hospitalization. The Seraphin study, again, of macitentan or Opsumit showed that in placebo, 22% of people every year got hospitalized. That's a lot. So roughly 1 in 4, 1 in 5. We didn't actually know that information before these studies. It also showed if you took the 10 milligrams of Opsumit or macitentan, it reduces that risk 50%. Really important. If you're not in hospital, it means you're feeling better. You're not lying in hospital 10 days, not participating in life, not able to move around and be active. So you're typically getting weaker. And it's a good sign that you're not in heart failure if you can stay at home. So really important that it cuts down on hospitalization. And then we mentioned quality of life. I had the great pleasure of being involved in this study, also from Seraphin, on macitentan or Opsumit, looking at patients' quality of life measured by what's called SF-36. So like emphasis we mentioned before. And what we looked at, it's a little complicated, but there's 8 different categories of symptoms we look at for your quality of life. So physical functioning, body pain, general health, vitality, emotions, social functioning. And what you can see is if you're in the red, that's placebo. Typically over 6 months, the values are going down, so your quality of life is getting worse. Not surprising. Conversely, in the gray, you're on Opsumit or macitentan 10 milligrams, the values are going up in 7 out of 8, and that's your quality of life getting better in 6 months. And we have data out to 1 year in this study and other studies now several years showing that quality of life does improve with many of our pH medications that are simple pills. So to summarize, 10 treatments, all very effective. Most importantly, you need to be on the right ones, and that depends on a good assessment, like we said, of how sick you are, your risk, and then deciding on the best treatment. So how do we do that? So the optimal management of a patient with PAH depends on 2 steps. You come in, first and foremost, we assess your clinical status. Simple stuff. How severe is your pulmonary hypertension? How severe is your right ventricular or RV failure? And related to that, what's my assessment of your risk of getting worse or dying in the next year? Really important. And then I also need to understand you as a person, your well-being, your quality of life, your values and wishes, what you want to focus on, how aggressive you want to be, what your tolerance is of the risk of infusions and other treatments. I also need to understand other medical conditions that you live with. Heart, liver, kidneys, liver, all of those things, scleroderma, which is common. Those are called comorbidities, other illnesses. And I need to know all your other medications because, of course, there could be interactions. So that's your assessment, step one. Step two then is saying, okay, based on that, what is the optimal therapy I need to offer you? And that could be medical, all the things we talked about, it could be surgical, it could be lung transplant. So let's look at how we do this. If you're a new patient that comes to us, we do that baseline assessment we already talked about, pH severity and risk, understanding you as a person and your other illnesses and medications. And then to give you optimal initial treatment for your pulmonary hypertension, most patients come to us, fortunately, intermediate risk, sometimes we're lucky, low risk. And at that level, most of us believe that you need 2 medications. But luckily, 2 oral medications or pills. You don't need the infusions. And that's called combination therapy. There's a minority of you who come to us and you're really well. You have very low risk, or it was picked up before you had symptoms, like on an echo, if you have scleroderma and your rheumatologist was looking for pulmonary hypertension. And there are some people that come in and have lots of comorbid illnesses, significant heart disease, significant lung disease. So I'm just nervous about throwing you on 2 medications for the risks and side effects. So those people, I will use monotherapy or a single oral medication. Now, really importantly, if you come in at high risk of getting worse and dying over the next year, for example, class 4, remember, you can't do anything physically. You're symptomatic sitting there, or you're having fainting or syncope, losing consciousness, or if you have severe right ventricular failure, we want to be aggressive. Typically, that means infusion prostanoids, intravenous, IV, or SC, subcutaneous, under the skin, plus 2 oral medications. So that's 3 medications to give you the best chance to get better now quickly, but also stay well for the long term. And because I'm nervous, if you don't respond, we're in trouble, we will also start discussions about future lung transplant. So this is the approach to new patients today. 2 drugs for most patients, 1 drug for a small number of patients, 3 drugs, including infusion therapies, for a small number of very sick patients. So that's at diagnosis. Then I follow you and I do that risk assessment repeatedly. I see how you're doing, hopefully better, symptoms, daily functioning, you're tolerating treatment, that's important, side effects, measuring your quality of life, and always asking you values, wishes, where you are, what you expect today and what you want for the future. And again, I reassess how severe is your pulmonary hypertension and the right-sided heart failure. And then what is your risk now? Typically, if you come in at the beginning, at diagnosis at high risk, you improve with treatment. At 4 to 6 months, you're usually lower risk, and that's important. Because even if you were high risk 6 months ago, that doesn't matter now. Your risk is now today. That's the important one that I want to know, because that tells us how you're going to be in the future. So what do we do? Well, for optimal maintenance treatment, not initial, but long-term maintenance treatment, it's a very simple question. Do I continue the treatment you started because I'm happy you're doing well, you're now low risk, maybe low intermediate, we can continue. If you're not doing well because you have side effects, then I'm worried. I have to maybe reduce treatment and then give you time to settle and then try it again, or perhaps change medications. Conversely, if you're high or intermediate risk, or high intermediate and still there, I'm worried. Whatever we gave you initially is not enough. This is where we then have to think about adding a 3rd medication. If you're high intermediate, we can try an oral medication. We have that, Selexipag or Uptravi. If you're high risk, then I really need to think about the infusions like we were thinking about earlier. And of course, starting lung transplant evaluation. So very simple, very stepwise approach, but it's not simple because every one of you is different. It depends on assessing how you're feeling, how you're tolerating treatments, what you want in terms of your treatment, your quality of life, and then of course, assessing your disease the best we can with all of those measures. One of the things that's important I mentioned is the tolerance of medications. Lots of medications, all of them have side effects. We're quite lucky. All of our medications largely are well tolerate it. And so we don't worry too much about this, but individuals are different and we have to pay attention to that. I'm going to pass on this for now because it's all fairly standard stuff. I'm actually going to jump forward and tell you what's happening today. PAH is now a chronic disease. Many of you are living longer. We've had people alive 25, 30 years. It is more common because of that. And on average, you're getting older. So it does make the discussion and treatments more difficult because clearly people are struggling with other illnesses, other medications that we have to look after as well. So that's one of the challenges we're dealing with. But the point is, people are living longer, they're doing better. And so to finish, we've had a lot of success. Patients are living longer, every day is better, quality of life is better, they have less complications. Sadly, not everybody. The reality is many of you remain ill, limited, symptomatic, and so we still need to find newer and better treatments and better approaches. And as you know from the discussion you had a few weeks ago with Dr. Langlaben, based on the science that I talked about, pulmonary hypertension, a whole host of new therapies are around the corner. I love the fact you see the red flags I've put in. All of those are Canadian research initiatives that are going to lead to new therapies for us in the future.
Thanks so much, Dr. Mehta. Jazz is asking about methotrexate being a chemo drug. Can that also cause PH? You were talking about chemotherapy medication. Is that one of those?
No, methotrexate is a very old drug, Jazz, and it's been used a lot. It can cause scarring of the lung in a small number of people, maybe 50%. And they, if they're really bad, could get PH group 3 in the long term, but we haven't seen that. The kinds of drugs that have caused it have been chemotherapy. So one drug that's used for leukemias called dasatinib is well reported to cause PH, and there's other chemotherapy drugs. Those are the ones I worry most about right now.
Okay, thank you. Do some people have risks in more than one level? I'm not sure what you mean, Sharon. Do you understand that one, Sanjay?
I think I can. So it's a very important point, actually, because, you know, in all of medicine, pulmonary hypertension, 5 groups. And it'd be easy if people just fell into one group. That's not the case. When you come to me, if you have some lung disease, could you be group 3? But if it's more severe with heart failure and you have scleroderma, could it be group 1? So the same thing with the risk. We think it's simple, low, intermediate, and high, but there are people that bridge across them. If you remember the green, yellow, red, nobody has all of the measures in just the green or just the red. People are people, so they're kind of all over the place. So it does make it more challenging to assess the risk. Clearly, what you want to say is your risk is more likely at worst this. I don't want to underestimate your risk and say, oh, you have a few red features, but don't worry about them. That would be dangerous. So we tend to err on the side of caution and look at the risk as the worst possible risk, which is why we've changed it now from low, intermediate, high to low, low, intermediate, intermediate, high, and high, 4 categories. And that does help us look at individuals better.
Réjean's been asking about apabetalone. I'm sure you can speak to that. Is there any research coming on that particular drug?
Absolutely. So first in English, apabetalone is a very exciting drug I mentioned that works on inflammation in the blood vessels of the lungs. And it's very exciting for us because our colleagues in Quebec City, Steve Provencher, Sébastien Bonnet, and their whole team have done incredible work showing it does work in cells in the lab and in animals with pulmonary hypertension. But of course, we need to test it in people. So they are setting up for a clinical study right now.
Jazz is asking, should we get RSV immunizations? That's a good question.
That's a very good question. And so vaccines are generally recommended for anybody with lung disease, including pulmonary hypertension. So clearly COVID, you were importantly at high risk, you wanted to get influenza every year. And RSV does affect people with lung disease, especially asthma, COPD, scarring of the lung. We haven't seen evidence that people with pulmonary hypertension are particularly at risk for RSV. But remember, once you're 60, now me, and over, we're all at risk for it. You can get severe pneumonia and there's a risk of dying. And so I worry about a lot of my PH patients. So I do recommend it because it is a lung disease. As we've said, many patients with pulmonary hypertension have heart failure. That's also a risk factor for RSV. So I would strongly recommend RSV for everybody with pulmonary hypertension. Very safe vaccine. We're giving it obviously to children. You should know it's not yet funded or covered by government. So if you have private insurance, great, it's covered. But at the same time, if you don't, then it is about $200, $250, I understand. But I think it's worth the investment.
Okay. Sue was asking a question that I was asking myself. You mentioned this issue of TAC with risk of using drugs. Can you speak a bit more to how that works? How does that contribute to pH?
I'm sorry, I meant TAC?
Yeah, remember you were talking about drug use and mentioned that there's a TAC deposit?
Oh, sorry, talc. It's
Talc.
talc. So
My
some of you might
apologies.
know this. I don't use drugs. Hopefully most of you don't. When people who abuse drugs, injection or inhale, they mix the drugs, opiates, morphine, fentanyl, cocaine, and often there's talcum powder in there. Some of you may not know talcum powder, but in brief, it's the kind of stuff that was first used as an anti-deodorant or antiperspirant. It's a white powder. We use it in baby powder. That's talcum powder. And so you don't know what's in there. But when you're injecting or breathing it in, that talc or talcum powder is getting in your lungs. That's what causes the scarring of your blood vessels that then leads to pulmonary hypertension. I can't get rid of it. Once it's in there for life. But you can see it in biopsies of the lung. So it's talc. Apologies.
No, my apologies. And so if you're using that in other products, I think it's in body washes or
Right.
deodorants or
Yeah, I know it's
putting the
very,
talc
very
powder.
low levels. It is safe to use. You're not injecting it, hopefully, into your blood vessels. And then even the inhaled stuff, it's recommended not to use too much talc, like talcum powder, baby powder, because you can inhale it. It doesn't cause pulmonary hypertension, but it does cause scarring of the lung. So that's not recommended either anymore very much. Small amounts.
Jane has a question. More people are using infusion treatments, IV sub-Q. Is this because the PH population is getting more ill, or doctors are treating the PH more aggressively, or is it something else entirely?
Well, super point, Jane. So I think it's all of those. We all want to be cautious. When you have oral medications, pills, and they work, who would want an infusion? Nobody does. I wouldn't, of course. But let's also respect the fact that, as I said, they are the best medications we have. So you don't want to sort of not use them when you need them, which is why at the beginning, if you're very sick, you should be on them. Fine. If you don't need them early on, lucky you, great. But I want to make sure you're getting better with the pills. If you're not well enough from what you tell me or what I measure, then we often go to them as well. They are the best treatment. At the same time, because we've held off, a minority of Canadians are on them, guidelines are always coming out and saying, you know what, we have not been using them enough. We should be using them more. So I think it's both of those things pushing us to use them. As well, if you're now living 5, 10, 15, 20 years and you're doing well on pills and you start to get worse, if I don't have anything else, why would I not use them? You're better, but I have the chance of keeping you well for a long time. So I think there's many reasons to use the infusion therapies. They are difficult and complex and risky, but still wonderful therapies.
Okay, thank you, Sanjay. Thanks so much. Have a great day. And Dr. Mehta, again, thank you so much. And
Oh, thank you so much, Kim, and thank you,
yeah.
everyone. Always great to chat. Looking forward for our next time.